All right, welcome to another AAPA EM self-assessment quick case. My name is Paul Jen. I'm here with John Mabey, and let's get to today's case.
All right.
A 40-year-old man is brought to the emergency department by ambulance because of diffuse painful rash on his body for 1 day. Over the past week, he's also had fevers, sore throat, and body aches. 10 days ago, he was treated with an antibiotic for a localized skin infection, which has since resolved. He has no other medical problems. Temperature is 38 degrees Celsius or 100.4 Fahrenheit. Pulse is 110, respiration 16, blood pressure 130/90. Exam shows a tender erythematous rash covering approximately 8% of the body surface area. Multiple bullae are present over the areas of erythema and on the lips and oral mucosa. Application of pressure to the bullae result in rupture and localized sloughing. There's marked injection of the conjunctiva bilaterally. Which of the following is the most likely etiology of this patient's condition? Autoimmune disease, drug reaction, herpes simplex virus, Staphylococcus aureus, or toxic shock syndrome? John, what's the answer?
All right. The correct answer is B, drug reaction.
All right.
So this is actually a classic case of Stevens-Johnson syndrome.
Okay.
And what we're talking about here with respect to mechanism is that typically it's like some drug exposure. There are a couple of other etiologies we'll talk about in just a second, but some drug exposure, like 1 to a couple of 3 weeks or so, prior to the onset of symptoms, where patients mount it's a hypersensitivity reaction where you get like cytotoxic T cells that actually attack the epithelium. Let me just go bullet through these other options. A, autoimmune disease is not the correct etiology here, even though it is. That's an immune mechanism, but it's not an autoimmune mechanism. Option C, herpes simplex virus. This is something we can see with
Erythema
multiforme. Thank you very much. I blanked out on that term. Staphylococcus aureus is option D. Could be something that we think about with like Staphylococcus scalded skin syndrome, but we don't see that clinical picture
More classically in infants anyway.
Right.
Okay.
And the last one, toxic shock syndrome, or TSS. So that's something that we typically associated with. The old one was like a tampon use.
Right.
We get toxin.
Retained foreign bodies, like the nasal packings or something
Exactly,
like that.
right.
Yeah.
And that's a multi-system, multi-organ, kind of significantly sick circumstance. Although even with SJS, or Stevens-Johnson syndrome, this is really a portion, it's a spectrum of disease.
Yeah.
Right, so Stevens-Johnson is like the lower end of the spectrum, and then we have toxic epidermal necrolysis, or 10 is kind of like the badder spectrum of this disease, and kind of arbitrarily we use like a 10% or less of body surface area involved for SJS.
Right. And then greater than 30 is toxic epidermal necrolysis. In between 10 and 30, they just call it the SJS-TEN.
Right, overlapper.
Yeah.
So the other etiologies besides drugs, just a word on drugs, there are multiple drugs that can do this. The classic ones are like antibiotics, they're anti-epileptics that can be involved. So with respect to antibiotics, trimethoprim, sulfamethoxazole, the penicillin group, particularly aminopenicillins, I think are notorious for this. The anti-seizure medications, phenytoin, carbamazepine, lamotrigine. So these are kind of classic drugs associated with that. But there are other etiologies, infections, malignancies, idiopathic even. Yeah. And then kind of like the picture that we saw in this particular case, oftentimes there's a prodrome, a set of symptoms that are associated with this.
Non-specific flu-like illness.
Exactly.
Oh, thank you.
So what does that mean? Headache, malaise, arthralgia, kind of like all of us typically have. But what we classically see with this is the pathognomonic rash. So pathognomonic rash. So we have a target rash, and then also there's mucosal involvement with this one. Yeah. That's really key.
Oral or the ocular or urogenital ones are the most classic ones.
Exactly. And then the other classic physical exam finding is Nikolsky sign. So Nikolsky sign is when you touch these bulla, push against these bulla, if they don't spontaneously rupture on their own. But just the sheer fact of pushing on them that induces these guys to rupture.
Just dissects down that plane, the skin just sloughs off. It's crazy.
Yeah,
crazy.
Pretty wild physical
Very
exam
painful
finding.
skin, that's for sure.
So let's take a look at a couple of images. Here's an individual with, you can clearly see healing lesions around the labial regions. And then if you took a look on the buccal surface, you'd see like lesions intraorally as well. You can see them around on his nose, his eyelid, even on his neck. So it's kind of like these scattered, diffuse skin lesions that we see. This next one, actually, this is a kid that is a photograph of someone who was there prior to exposure, and then after the drug exposure, the offending agent. We clearly see, this is a huge, and this is falling really into that more 10 spectrum of disease, where you have widespread epithelial involvement here.
Oh man, ocular, oral involvement.
Exactly,
That's
right.
skin sloughing off on the cheeks. That's so sad.
Yeah, it's a sad image to see. And here's actually an image of the tongue where we see like a sloughing of the mucosa on the surface of the tongue.
Yeah, that's a horrible case of mucositis.
Right.
Okay.
Right.
Yeah, I mean, it looks like gunk on it, but that's actually the epithelium of the tongue.
Right.
Ouch.
That's sloughing. So some of the key pieces to remember also that are testable is like, so what do you do?
Yeah.
For this, clearly stop the offending agent would
Makes
be
sense.
like a first thing to do. And these patients really can be sick or get sick fairly rapidly if the disease extends. So, one of the main things we're concerned about is like a fluid and electrolyte losses, acid-base challenge or changes even in these individuals. So these are folks that really need to be brought into the hospital, managed.
They
in
usually
the
go to
ICU.
like burn ICUs.
Yeah, burn
Just
ICU.
because the mortality, I think, is in the 20-30% range.
It's really, really
crazy.
significant. Right.
Yeah,
and this would actually be an indication for like an emergent dermatologic
That's right.
consultation.
The one time the dermatologist really needs to come in from home in the middle of the night.
So you really clearly need expertise with respect to managing these individuals.
Cool. All right. Well, that wraps it up for this quick case. Thanks, John.
Good deal.
We'll see you next time.